Thank you, Uma, for making me part of this nice and IC. I have no financial interest in the mention of any products or procedures during the course of my talk here. Over the next 10 minutes, I'll walk you through the surgical management in keratitis. This will be largely pertained towards fungal keratitis per se, but largely you will not see much differences, but I've kept it pertained to fungals because I'm going to highlight to you the recent aspects based on what we know about therapeutic keratoplasty in fungal keratitis on evidence based depending on all literature which we have with us. So when you look at fungal, you have at least 26 to 35% of fungal keratitis will require grafting in the acute stages here. And the problems with fungal is recurrence of infection, secondary glaucoma, graft rejections, and the functional success following a therapeutic keratoplasty. So these remain a pertinent aspect when we are doing therapeutic keratoplasty for our patients. And in India, largely, we do have a predominance of fungal keratitis in our patients here. So I largely do reserve my therapeutic keratoplasties whenever the ulcer is chronic. So again, chronicity differs the way we are defining it, and chronicity differs about which region of the cornea is going to be affected. So we largely look at it when an ulcer is present for more than 3 weeks, and you're going to look at chronicity, and you would need a therapeutic keratoplasty to debulk the infective material from the ocular surface in these cases here. So therapeutic keratoplasty can be largely diagnostic. So if you're not able to get a microbial diagnosis, then you would probably need that tissue to be sent over to get a diagnostic of what etiological organism is causing the ulcer or the microbial status here. You would need it therapeutic when you need to debulk the ocular surface where it's been on the ocular surface for a long period of time and it's not responding to the medical management here. Again, prognostic. So prognosis is what you need to give when you're doing a therapeutic keratoplasty, and you're going to see how you're going to change the course of events on this surface which has become infected here. So I think Uma covered most of the diagnostic approaches, and Dr. Charu also detailed you how you would go about looking at the microbiological diagnosis of here. So this is a fantastic paper which talks about outcomes of therapeutic keratoplasty from a tertiary care center in northern India here. And therapeutic penetrating keratoplasty definitely has a role in managing both severe and refractory keratitis, and helps in restoring the tectonic integrity and the anatomical integrity here. The functional success depends upon the graft clarity, and that largely will depend upon the quality of tissue you're using and the morbidity of the case you're going to be dealing with, and in cases where your limbal and scleral involvement are also going to be present here. So that's going to dictate the outcome of your cases here. Again, fungal keratitis still remains the larger percentage of the cases which we do see here, and the prognosis is poor in your cases. And I think this largely also will apply to your bacterial cases. Whenever they are large ulcers, ulcer over 7 to 8 millimeters will have a bad prognosis here, and when those which have perforated early, so when you take them again, their outcomes are going to be less favorable vis-a-vis when you do it earlier on in these patients here. So looking at the predictors of corneal perforation for the need for therapeutic keratoplasty in severe fungal corneal ulcers, the depth of the infiltrate size and scar, your visual acuity, the presence of a hypopion are all significant factors which can influence the final outcome after you perform a therapeutic keratoplasty. So clinical examination at baseline is very important to identify those fungal ulcers which are going to need an early intervention here. I think I would not delve more into the theoretical aspects here, but whenever you have an involvement of the posterior third of the cornea, the risk of perforation is much higher, and the need for therapeutic keratoplasty is again going to be is higher. So it's better on to do a therapeutic until without waiting for a perforation in these cases here. So per se, it helps you to debulk, it helps to restore the anatomical integrity of the ocular surface, and it would, if you're successful in containing the infection with postoperative medications, meaning you have an early diagnosis and you also have your culture sensitivity and it is covering your organisms well, then you would also get a functional success in these cases here. I largely reserve my therapeutics to those more than 6 millimeters, impending perforations or perforated ulcers, and to establish the cause of the organism as well here. Again, when you're doing therapeutic keratoplasties, it can be a full thickness penetrating keratoplasty, or it can be a lamellar. So when you are doing it for bacterial keratitis which are on their healing stages and your posterior one third or posterior half of your stroma is not involved, then you could probably consider a therapeutic deep anterior lamellar keratoplasties. This per se, probably you will have to be more careful if you're looking at acanthamoeba and you're looking at fungi. You will have to be absolutely sure that your antifungal therapy is containing the growth of the organisms, because you can never be sure that the posterior third is free of involvement, and perhaps a confocal, if possible, can help you to identify the depth of infections. Again, patch grafts, if they are small focal infections, small areas which are perforated, then you can look at a patch graft for these cases as well. Again, points to notice: have your diagnosis before you're delving in for surgery. The timing of surgery is going to be pertinent. So several times I see my residents that they find a case, they immediately admit and put it up for surgery. But I would always like to wait for 24 to 48 hours, that you take care of the ocular surface with the amount of fortified antibiotics here, so your medical therapy is maximal before you take them on for a surgical intervention. That always helps you to get a better outcome when you're better outcome in terms of controlling your infections when you are managing the patients. The approach to the surgical steps and the postoperative management are all important aspects when you're doing therapeutic keratoplasty here. So factors to be considered: microbiological diagnosis, indications for surgery here, and alternatives to therapeutic keratoplasty. So Paris nicely covered what are the various alternatives here. So that's when you probably will also need to know when you need to adopt alternative approaches and rather not do a therapeutic for this particular patients here. So I'll quickly move on to the surgical steps here. The first is the host trephination, the anterior chamber handling, donor trephination, management of other features in the anterior segment, the lens management here, and suturing concerns. So one by one, host trephination. This is a case we would always do the host trephination first here, and you ensure you give a free margin of the necrotic tissue here, measure your host window again, and then reconsider the donor trephination is adequately covering and adequately sizing. So this usually is a problem for those who are learning. They tend to downsize here and land up with a flat graft because of a tight suturing. So that's a problem which you need to be looking at here. Anterior chamber, several times you might find inflammatory membranes lining the iris, so that's something you need to take care of. Wash the anterior chamber angles here, because you might have infective material sitting there. Your lens, I largely would prefer not to handle your lens until and unless it's a total cataract which is sitting there, or an intumescent lens which you feel you need to remove, because that's going to compromise your anterior chamber depth after you've done your suturing here. Donor trephination, as I told you, needs to be adequate and of adequate size depending on the final host window diameter, and that is a that is something you need to take care of on your graft host sizing here. Lens management, again, do not take out your lens unless you really need to take them out here. Suturing is important, and for beginners, as I already pointed out, do not do not land up doing flat tight suturing, and then you would have a problem in these cases. So this is a here you could see this is a case where the central cornea has become very necrotic. It is already thinned out and it is perforated in perforated in the central region here. It's a flat anterior chamber which you are having in the beginning. So general anesthesia is always desirable for these cases here, and would not attempt to give a block here. But in dire cases, if you do need to give a block, a facial block as well helps you, so that it gives you more comfort when you are managing these cases here. So measure the region, and a handheld to delineate the region which needs to be to find out. And in this particular case, I was lucky to get a good trephinations, partial trephinations, and then complete it. So you can see there are some pupillary membranes here, and if they are there, then they need to be removed. And a good quality donor tissue is always helps if you find those cases which are going to have an optical result here, and then go ahead and complete your suturing and form your AC here. I per se tend to do my therapeutics with lesser use of viscoelastic, so that's something I always like, the lesser viscoelastic, and I keep reforming my AC with BSS and with saline. That also decreases your inflammation quotient in the postoperative period, and the IOP pressure quotient as well in these patients here. So this is how, this is just one of the case. And then moving on to certain aspects of adoption of therapeutic DALC for our patients. That's when your anterior chamber imaging largely helps you to look at the involvement of the posterior stroma, and when the posterior stroma is largely clear, you can go ahead and do a lamellar keratoplasty. So therapeutic DALCs for these patients, it will be manual DALCs, and you can create create the lamellar graft to the desired depth, depending upon the depending upon the amount of tissue which you are removing. These give you fantastic results here, and they also help you in good visual rehabilitation of taking the patient up to 618 or so, because the residual stroma does have some amount of opacity, or it's not that transparent when you do it, but that's another alternative when you like to contain your infections. But you will need to look at and select your cases very carefully in these patients. And in the term of recurrence, you can probably just pull out the graft and then replace the grafts in such patients here. So this is just to close with a very rare appearance of a primary corneal acrimonial eumycetoma, which looked like an anterior staphylomas, which we did when we first saw it, and we had to take this patient in for a therapeutic keratoplasty at the end for this patient. I think I will close here, and we will take questions if we have any. Thank you.
Thank you for that excellent talk.